Motherhood changes your body, but does it change your confidence? In today's episode, we're diving into the mommy makeover, when to consider it, what's involved, and whether you're ready to reclaim your pre-baby self. Stay tuned because the journey to feeling like you again starts here.
Welcome to The Doc Dudes, your premier podcast for a behind-the-scenes look at the latest in aesthetic medicine. Hosted by the cosmetic surgeons at Graper Harper Cosmetic Surgery in Charlotte, North Carolina, The Doc Dudes brings you interviews with insightful guests, expert tips from experienced medical professionals, and lots of laughs along the way. And now, here's Dr. Garrett Harper, Dr. Robert Graper, and Dr. Evan Zug, also known as The Doc Dudes.
Welcome to another episode of Doc Dudes. I am Dr. Garrett Harper, joined today by
Bob Graper
and
Evan Zug,
all board-certified plastic surgeons,
Yay,
which
Evan.
is pretty
Yeah,
fantastic,
baby.
right? All right,
Thank you.
so we are going to talk about mommy makeovers, and I'm just going to kind of shoot at the hip with both Doctors Graper and Zug so that we can get to the nitty-gritty on this, and we'll go over some specifics, obviously, what a mommy makeover is, what can it entail, and all those things. But I think, I'd start off by saying, obviously, a woman's body changes with pregnancy. It has to accommodate a growing uterus. And so there are different elements to correcting some of the problems, some of the changes that occur with pregnancies. And as just a general guideline, a mommy makeover typically is something that combines breast and tummy work, right? It doesn't mean it stops there. Sometimes there are other areas that need to be operated on as well. And we can talk about some of those things as well. But for today's purposes, this is kind of, all right, what happens after your milks come in or you've gained the weight during pregnancy, you've stretched out your muscles, all those types of things. Also, I'm going to talk about some misconceptions, one of which I just kind of used and shouldn't, because I get angry when people say things that, like, oh, my muscles are damaged. Your muscles aren't damaged after pregnancy. I promise your muscles are right where they're supposed to start, right where they're supposed to end. We just got to sometimes get them in the right alignment. So we'll talk a little bit about that today. So Dr. Graper, somebody comes in and says, I just had my second kid. I'm not having a third. We know that. Husband got a vasectomy. I got my tubes tied, whatever. I'm about 2 months out, still breastfeeding. I just don't like the way my body looks, and I just want it back to pre-baby, and it's May, and I want to look good for this summer. What do you tell those people? A lot to ingest there, right?
Realistic expectations. Give your body a chance to get as good as it's going to get. Wait till you're done breastfeeding. Let the skin recover. Let your muscles get stronger. And this summer's probably not your optimal time, but, fix what you can fix without surgery, and then give the body time to be in a stable state, and then assess the breasts, assess the tummy, and anything else that comes up.
Yeah. So Evan, patient comes in and says, hey, I was 5'6", 140 pounds prior to my pregnancy, and I gained 80 pounds. So I was 220, but I'm at 180 right now, and it's been a few months since my pregnancy, and I'm just I want to get this thing planned. I'm sure you probably tell post-pregnancy patients the same thing you tell anybody that you're getting ready to do a tummy or a breast procedure on, right? Which is what, as far as timing of this for them?
Yeah, it's always best to have, for any cosmetic surgery, to be at your optimal weight. When someone needs to lose some more weight and we do a tummy tuck, then they may have some extra skin after.
Right.
They won't be happy with that. So I always try to get patients to, work with them and get them to that weight that they're going to be at before surgery.
I'll tell people, they'll come in and they'll say, I've tried everything, right? I was 140 pounds before I had my two kids, 160, and I just, I've tried everything. And I'm like, you've tried everything? I'm like, have you applied to be on Naked and Afraid or the Survivor series? Because you will lose weight if you do that. And they're now, I think, with the GLP-1s, right, and the different kind of iterations of those, it's much more achievable for them. And yes, we don't want people going on split pea soup diets and not doing it healthy. We need protein. We need all those things for our patients to be able to heal. And we want them to be healthy, but we don't want to put the cart before the horse, right? And so for everybody, this is elective surgery. You want to do this once. We want to restore everything. And the best way to get the greatest result is for you to get closer to your goal weight. Now, what I also tell people is you're 140 pounds prior to the changes in your body that happen, even musculoskeletal wise with some of these patients, right? So it's like your hips may be broader now. You may have a different shape to yourself. You may just kind of hold weight differently. So to think about getting back to 140 pounds, I mean, my kids make fun of me all the time. I'm not going to get back to my 18-year-old self either, right? Things have just changed.
Not unless we imprison you in a barbed wire fence.
Or took away McDonald's, and those would be your options,
Would
right?
be
I know, but
unthinkable.
I know, but the nurses here are the ones that always try to talk me into ordering McDonald's for everybody. So it's their.
And you succumb to the nurses.
I'm just a nice guy. I just want to please. All right. So back on this, it's one of these things where you got to, give yourself grace. Be easy on yourself. And 140 pounds, your college self may not be what is attainable anymore. And it may not be where you need to be. Because what I tell people is, I don't want fluctuations in weight either way after your surgery, right? Like, I don't want you to lose a bunch of weight or gain a bunch of weight. So I don't want you to starve yourself, and we make decisions on the table, and then, your breasts are a certain size and shape and you love them, and then all of a sudden you gain 30 pounds back because you couldn't do that. Now your breasts are huge again and you're back doing something else. So it works both ways, right, Evan? So it's one of these things where I want you to be at a comfortable, manageable weight prior to your surgery, okay? And so straight out of the cannon, how long do you tell people that they have to stop breastfeeding before you'll operate on their breasts?
I think the milk ought to be done. So if you stop breastfeeding and you're a month later still leaking milk, I would wait for that because I think you're not done.
Right. And so I think the board answer would be 3 months, right? Somewhere in there. And so what I typically tell people is that the likelihood of you having galactorrhea, which is, milk production still in the glands after you've stopped breastfeeding for 3 months, is low. It ain't zero. I mean, I can tell you, I think it was last year I had a patient that we made an incision in the breast, and it was unbelievable. I just hadn't really run into that. So it can, and you can have problems by cutting through and cauterizing and doing stuff like that to milk ducts. You can get galactoseals and things like that. I've seen that in plastic surgery. So we just want to make sure that you are at a manageable fighting weight that you're happy with making decisions at, and that you haven't been breastfeeding for 3 months or so.
Stable.
Yeah, that's a great way to put it. We also want to make sure that you have, right, support network, right?
Who's going to take care of those kids?
100%. Not only the kids, but who's going to help you take care of yourself.
Who's going to take care of the dad?
I know. Yeah. It's like me. He's like not going to know where plates are or anything like that.
I feel like
right?
that's the biggest deterrent for young moms is, that they still have young kids. And so they're like, I don't want to have a tummy tuck right now.
Yeah.
But
yeah. And I tell them, though, I'm like, I also think that it's good. And that's why it's nice for people to kind of hear this podcast, because I think they have some preconception that like they're not going to be able to be a mom for 3 months. And I'm like, are you kidding? If it was 3 months before you could go back to doing mom things, there would be no mommy makeover because we would never make over any mommies.
I don't know about that. There'll be a lot of ladies that sign up and say, you don't have to be a mom for 3 months. Sign me up.
That's right. But I do tell people, especially if we're doing a tummy tuck, especially if we're needing to bring their muscles together, because again, this is a combination of breast and body. It can be liposuction. It can be removal of skin with or without muscle plication, all those different things. Plus, added to breast surgery. The good thing about breast surgery now, when you do breast surgery along with a tummy, oftentimes you're not paying attention to the breast component, right? Like your stomach's kind of sore enough to where you're really focusing on that. So let's talk about when a patient needs you to plicate or bring their central abdominal muscles together. And we're talking about the muscles, the rectus muscles that go from the bottom of your rib cage, right where your sternum is, your midline. It's that center kind of running up and down muscles that cause your six-pack, or the six-pack that you used to have when you were younger. And then it goes on either side of your belly button, and then it inserts down on your pubic bone. So what can you do to a patient? How can you evaluate them, Evan, to know that they need you to bring their muscles back together? Because their muscles aren't, unless they've had like some C-section, which even now, there's non-muscle splitting C-sections, but for all intents and purposes, their muscles are fine. They're just not where they're supposed to be together. So how can you decide when somebody stands up and shows you their abdomen and says, "Do I need my muscles done?"
Yeah, I usually have them lay down on the exam room table and lift up their legs, and then you can palpate and feel, how separated their muscles are. And some patients, it can be kind of difficult to tell, and you have to have that discussion with, well, we may need to placate your muscles in the operating room, but
Right. And I let everybody know, even if you're just, if you got a whopping, gaping, separation of your muscles, they've got to come back together for you to get the optimal result. But there's plenty of people who come back considerably well, right? And they look almost great. And I'm kind of like, yeah, but you're going through the whole surgery. Like, even if you're a half an inch separated, don't you just want to get back to where you kind of were? And I use two kind of levels of stitches. I do a running barb stitch that your body will absorb after 3 months. And then I use figure of 8 permanent sutures that are soft, but it's kind of a belt and suspenders, and probably is unnecessary. But
sometimes it can just be like the lower half of your
depends on where you hold
like below your belly button.
Yeah. Which can make things much, much easier. So that's right. You only got to kind of bring the muscles back together where you see it separated. And I tell people, I mean, you can't cheat when we're in there, because you're asleep and we can see where that muscle edge on both sides are. And when you see where they are, you can put them back together. But if I have somebody stand up, it's funny because they can have a flat abdomen, look great. And I think most people would get this reference, but I basically just ask them, have you seen the movie Frozen? And everybody's like, oh yeah, I got kids. I've seen the movie Frozen. And I'm like, all right, Elsa, just let it go. Just let it go. Don't suck in anymore. Don't do any of that. Just because you can see the shape of their abdomen drastically change, and unless they're sitting there firing off, sucking in their abdomen, which is great now. But I mean, you don't want to have to do that always. And so, if by virtue you're here wanting us to evaluate your tummy for a mommy makeover, because that's what it's going to say on the sheet before we go walk into the exam room, let it out.
Try to look pregnant.
Let us see what it is so we can figure out exactly what needs. Because, Evan, you're right. I don't want to go into the operating room and not having had that discussion, or feel like I've been tricked because they've been sucking in and look great. So it's one of those things where I tell people, if you're separated, I want your permission to be able to put you back. It really doesn't change their recovery, especially if they're kind of borderline, because we're all going to heal in the same kind of general timeline. I'm not going to have them back working out, doing core exercises any sooner if I do or don't do that, right? All right, so that's kind of when we see, I always tell people also, I'm like, a lot of times when you're in the plank position, you like see this alien like thing kind of coming out of your abdomen in the center of your abdomen, and that's what it looks like. And that's that diastasis as well. So good thing is that we have numbing medicine now. So what's the numbing medicine that we use, that we inject in the muscles and along the incision to help post-operative pain and discomfort, Dr. Graper?
It's straight Kentucky bourbon.
That's right. That's exactly right. Hopefully
it's
something from Heaven Hill or
Exparel.
Yeah.
And it's really pretty cool stuff. It's lidocaine, or actually marcaine, in bubbles of fat that slowly release over 3 days.
Yeah.
So if you put that in the tissue planes where the nerves are, it'll numb them up for 3 days, which is certainly the most intense period of post-op discomfort.
Right. And so when somebody asks, Evan, what's my recovery going to be like after a mommy makeover? They need a breast lift. Maybe they need implants, and they need a tummy tuck with a little bit of liposuction. What's their general timeline of like, hey, when am I walking normal? When are drains going to be out? When am I able to drive a car? When am I back to work? When am I exercising again? When do I not even remember having this surgery done?
Yeah. So, I mean, I typically tell patients that first week after surgery, you're not going to be happy with me. You're going to be really uncomfortable.
Yeah.
Typically we'll have a drain in place. It'll come out after a week. Sometimes there's 2 drains that come out at a week and 2 weeks. And then, if we're doing a full mommy makeover, then it's a good 4 weeks before I want you exercising at all, or getting your heart rate elevated. And then after that, it's kind of patient dependent. But if we're doing a full muscle application, I don't want them really exercising their core for a good 3 months.
Yeah, and I think there's levels to exercising, and so I tell patients I don't want you to sweat for 2 weeks. right? Nothing that makes you sweat. Don't get your blood pressure or heart rate up too much. And then, we send patients home after their tummy tucks with a walker. And you say that right to them, and you're like, hey, for the first week, you're going to be bent over using a walker, and they're freaking out. They're like, and I tell them it's not because you're incapacitated or anything like that. From my standpoint, it's because we've got blood vessels that have to travel a lot further distance now to provide your tissues with oxygen and red blood cells. And so blood vessels are tubes. And if you take a tube and you put a tube on stretch, the diameter of the tube gets narrower and narrower and can't deliver oxygen as well as when you're bent over. So I tell patients I want you 90 degrees. And so, sitting with good posture, flat back, try to keep your shoulder blades engaged, sleep in a reclined position. Certainly probably for the first 2 to 4 weeks in a reclined position, just some pillows behind your head and pillows underneath your knees. And then, at 2 weeks, I tell them you can get your running shoes on. You can start walking in the neighborhood. Like, you don't need to be jogging. You don't need to do anything crazy, but you can start getting your blood pressure and heart rate up a little bit. At 6 weeks from any surgery, your tissues are 60% their final strength. At 8 weeks, you're 80% your final strength. So I tell them it's then when I feel comfortable with you starting to kind of push the envelope a little bit. I tell people the first thing you're going to do is not a burpee. You're not going to do a Rocky Balboa inverted, crunch. You're not going to be doing overhead slams. You're not going to pull out your driver. But, you can be out there and doing some movements and listening to your body. By that time, you're probably still sore. You can still be swollen. You're going to be wearing garments that are going to be supporting you, right? Your bra is going to be supporting you. Your binder is going to be supporting you while everything's healing. And then, I think, you don't even remember that you had surgery at 3 months. And I typically say that people look their best at 6 months post-surgery because they're close enough to having their surgery that they're eating healthy, they're in the gym, none of their bad habits have really crept back in, but they're far out enough to where they're looking great. The swelling's gone, the bruising's gone, everything's kind of where it's at.
And compression's really important too, especially if we're doing liposuction.
Yeah.
Super important to wear compression.
Yeah, I think it's critical. I think we're just now starting to appreciate as plastic surgeons that compression garments and lymphatic massage therapy are really separating results. And so we have all our patients go see lymphatic massage therapists. You want to get that fluid out of there. I think it's the fluid that sits within the tissues, settles within the tissues. That
fibrotic.
That's exactly right. Yeah, that's exactly right.
I try to get them in within 48 hours till, everyone has different opinions on when they want to get them to a lymphatic massage specialist, but I try to. And we have people who will come to your house and do it for you.
Very convenient now. And so I think it's an important kind of component to their healing process, right? We can do all the taking collagen supplements and eating lots of protein and doing all this kind of stuff. But I do think that management of their post-surgical edema and swelling is critical to getting the best result. 100%. All right. Let's talk about the breast kind of component to a mommy makeover. So, how do you handle somebody who just comes in and says, I don't like my breasts, Dr. Graper?
I try to figure out what they don't like. Yeah. So make a diagnosis. Are they too big, too small, too droopy? What is the issue? And go from there.
Yeah. And so if they tell you, and I normally will just ask, when your breasts are in a bra, are you happy with your volume? Right. And so if they say, no, I've lost volume. My breasts used to be perkier. I used to have more cleavage. I used to have more upper pole fullness. And you're kind of chatting with them about using an implant. Talk a little bit about implants. And we're going to have a whole different podcast on implants all by themselves. But just, briefly so that people understand, you've got saline, you've got gel implants. Which ones do you prefer? Which ones do you choose? What's gummy bear mean? Is there any particular implant company that you think is better than the others? What's your general 2-minute kind of spiel on implants?
Well, implants have started in 1962 with a guy named Cronin in Houston, and now we're on probably the 5th generation of implants. They're the best they've ever been, and because they're so much better, we can now put them on top of the muscle rather than underneath the muscle, which is a big improvement in post-op discomfort. And people who may have needed a lift in the past, some of those will get by with just an implant alone under the skin, which is, of course, where the breast is anyway.
Right.
Saline implants came out about the same time silicone implants came out, but I think everyone recognizes now that silicone implants are far superior and easily as safe.
Yeah.
Cohesive implants are a new component where if in the past an implant had a hole in it, the silicone was gooey, runny, and it would spill out kind of like honey.
Sure.
Now, this is the derivation of the term gummy bear, where you buy gummy bears at the grocery store or the movie theater, and you bite them, cut into them, and they just are cut. They don't leak at all.
Hold their form.
Yeah. So now the implants have this cohesive gel where if they get a hole in them somehow, nothing changes. And so I don't know if you had I don't even know how you would rupture a cohesive implant, maybe a auto accident or something.
Stab wound, shotgun blast.
I'm not 100% sure you'd have to change them. We probably would, but if the silicone's not migrating, you don't really have to. Sure. So implants have come a long way. The capsular contracture rate, which is a scar formation that's excessive around the implant, is down to very small numbers now. Yeah. And that's a function of better implants and better technique.
And better strategies, right? We employ all these strategies to try to minimize that.
Saline implants are certainly safe, but they ripple frequently, and rippling is very unnatural, and they change the lower pole more than they do. They don't hold the upper pole fullness, which is real important. And what do you think? Dr. Zug, what do you think?
In regards to saline versus silicone implants, there's just not even a comparison. There are some patients who really want a saline implant, and I try to have the same discussion with them that I don't think they're going to be happy.
Yeah. I don't think I've put a saline implant in 10 years. Yeah. It's been a really long time. And I think the data tells us that it's, there's just fewer complications. It feels way better. It looks way better. There's not the water hammering inertia
effect.
It's a very
unnatural feel.
Yeah, it really is. And just the shape of the device, it blows up kind of like a balloon. There's not a front and back to it like there are with the gel devices. But, look out for the podcast on straight up on implants themselves, and we'll kind of go through myths and more details about them. But that's one kind of component to a mommy makeovers is the use of that. Now, Evan brought up liposuction, which is almost always kind of combined with tummy tucks at least. And there's all sorts of different things, right? Like if you don't like your rear end or you don't like certain parts of your body that maybe need supplement, fat grafting is another avenue that we can use for mommy makeovers as your body kind of changes and shifts and all those things. So that's another kind of component to things, right? Like getting rid of some of the cellulite that you use with the Ovally system and that. So there's some really great opportunities to rejuvenate, head to toe. It just really depends on what bothers you. And that's one of the things that we try to do when we go in for examinations is just really get down to the nitty-gritty and figure out what the patient's concerns are and what bothers them the most. And then we can kind of set up a game plan for all these things, which is great.
Can you do them at the same time?
You can. I always do, tummy, breast, torso, that kind of stuff at the same time. I think if you're getting down to somebody who maybe is more borderline, they're a mommy makeover, but they also kind of maybe had a lot of weight loss, then I think you start thinking and approaching those patients less like the mommy makeover patient and more like the massive weight loss patient, where you have to kind of stage and think about, all right, we're going to have 2 shots at this because we just have to separate it from a time standpoint. I just don't want you on the OR table for all day or anything like that. And I also don't want you incapacitated. It's like you start doing circumferential all the way around tummy and
arms,
buttock
and
lifts, arms and legs. You're like, how are you going to move? How can you even take care of yourself? So you got to plan for those things and be smart, because a patient that can't take care of themselves afterwards and just sits around, gets a blood clot goes to their lungs, goes to their heart, goes to their brain, they die. It's not a happy patient.
No, we don't have the D word.
It's not a happy patient. It's not a happy patient at all. Okay, so somebody comes to you, Dr. Graper, and says, I've had 2 kids. It's been a year. I'm down to my fighting weight, but I don't know if my husband and I are done having children, but I really want to get my tummy tucked on. What do you tell that patient?
Well, I'm very practical, so I say figure that out and then come back. But I certainly have friends that thought they were done and did tummy tucks on them, and one of them came back and had twins and had another tummy tuck. So I don't think that's an optimal result for a patient.
Yeah.
But so for me, the answer is usually y'all figure this out, and I'm here when you're done.
Yeah. So you would encourage patients to be done with their pregnancies?
Me, I would. Doesn't mean that is what everyone should do, but that's how I would deal with that.
Yeah, and I agree 100%. It's typically, it's kind of funny. It's most moms that come in,
their bodies look so much better. It's difficult to not get pregnant.
But they tell you, right? They tell you when you're first seeing them in consultation, my first kid was fine. I look great, bounce back. My second kid was fine. It's always the last kid, right? And maybe that's what like stops the whole pregnancy thing. But it's typically always that last one. So you're like, oh man, I'm the same as you. This is elective surgery. You want to time this correctly. If you guys are still thinking about having kids, have kids. If you wanted to do something that didn't burn any bridges, like get a breast lift or something like that, like that's not a big deal. But but I think plicating, specifically for me, because I do use those kind of permanent Ethibond sutures, I tell them wait until you're all done with everything. I just think it's important. And then
I view our job as taking care of the patient, and if you know what the future is for them and they don't know, and just because they want it doesn't mean it's the right thing, and we have to kind of look out for them, not just medically, but sort of, I don't know, what's the word for that? I don't know about financially is not exactly the right word, but take care of the whole patient.
That's right.
And do the right thing for them.
Yeah. And I think so long as you give them like a realistic expectation and a realistic understanding of what the recovery is and how what we do is going to change your body and how any major changes from what we do, how it can affect your final result, how it can affect the longevity of your result. I mean, ultimately it'd be great if we could put things exactly where we think they should be, where the patient wants them, and we just kind of snap our fingers and it stays there for forever. But that's unrealistic. So certainly with major body changes, including pregnancies, including weight gains, weight losses, those types of things, it can make that even more difficult to navigate through the years. So
I have two things I want to throw in. All of a sudden thought of.
Yeah.
When people ask, well, you've talked about this as tender. How tender is it? What I usually say is it's like a C-section. Some say it's worse. Some say it's better. Yeah. So it's in that range. So people aren't like, oh my God, this is going to be terrible. No, it's like a C-section. The other thing, going back to muscle plication, is we all know there are two types of fat. There's intra-abdominal fat and there's outside fat.
Oh, yeah.
If they've got that intra-abdominal fat, even if they have a diastasis, you're not going to be able to compress that very much and the way to test that is, you relax your tummy and then you push in it to make it flat. And if you got to push really hard, those sutures are not going to be able to stand the tension, and they will tear through that tough connective tissue, and they may be worse after that than they were before, because now you've weakened it. So somebody might say, well, I really want my tummy flattened. Well, we got to get rid of that intra-abdominal fat, and that is just nothing but diet.
That's weight loss. There's no other way to do it, because I tell people it's like you got people trying to get in and out of a room, right? And if you've got people pushing on a door in one direction, which is what that intra-abdominal fat does, that visceral fat, it's pushing out on your abdominal wall and making it that round shape. And so, the worst thing, it's just a more difficult recovery too. It's one of the reasons I tell people it's best to lose that next 10 to 15 pounds. And I'll typically tell people, look, I wouldn't agree to do your surgery if I didn't think you weren't going to get a really good result. But do you want a really good result, or do you want a great result? Or an awesome result? Or
the better
freaking fantastic result, right?
Best result.
That's exactly right. So you just got to, I think the importance, like any cosmetic surgery, the importance of making sure that you are as healthy as you can be prior to getting your diagnosable problems fixed with a concrete, clear, reproducible plan, I think is the safest way to kind of get a good result and get a happy patient, which is what we love. 2 really good points. Thanks. So I hope you've got a good understanding of mommy makeovers. We'd love to see you. If you have any questions, come in for a consultation. All 3 of us do mommy makeovers and I think do a really great job. So if you've got questions or topics you would like us to cover, please visit ghsurgery.com and click on the Doc Dudes from the homepage. There's a link to click to submit your questions and ideas. Subscribe to the Doc Dudes so you never miss an episode. New episode drops the last Tuesday of each month. You'll find us on Apple, Spotify, YouTube, and anywhere you listen to your favorite podcasts, as well as from our website. Follow us on Instagram and Facebook to find out when new episodes drop and other information about our practice. Thanks for listening to this episode of Doc Dudes. I am Dr. Garrett Harper.
Robert Graper.
And Evan Zug.
Sayonara.